Okay, we should be, let's just wait 1 or 2 more minutes because I think there was some slight technical issue, but let's start. I'll tell you when we're going to start.
Elizabeth, you can start.
Good morning. I'm Elizabeth Kwaovi, and welcome to the WHO Africa media briefing, which is taking place in collaboration with the APO group. First, some housekeeping. You can choose the language you would like to hear for the press conference by turning to the globe on the bottom right and select your language. Bonjour, je m'appelle Elisabeth Kwaovi et bienvenue à ce point de presse qui se tient en collaboration avec le groupe APO. Quelques questions d'intendance et pratiques. Vous pouvez choisir la langue de votre choix en cliquant sur le globe en bas à droite de votre écran. Joining us from Geneva, Switzerland, is Dr. Matshidiso Moeti, WHO Regional Director for Africa, and I will let now Dr. Moeti take the floor to introduce our other panelists.
Good morning and good afternoon. Bonjour, and welcome to all the journalists joining this press conference, where we'll discuss treatment access in the COVID-19 pandemic. I'm pleased to be joined today by Dr. Andrea Howard, the Director of the Clinical and Training Unit at Columbia University in the United States, who will discuss the lessons learned from the fight against HIV. This is an area of particular interest for me, having worked extensively myself on HIV treatment acceptance and equity. A warm welcome too to our second speaker, Dr. Harley Feldbaum, Head of Strategy and Policy at the Global Fund to Fight AIDS, Tuberculosis, and Malaria. Dr. Feldbaum will talk about the fund's efforts to increase access to COVID-19 treatment. There have now been more than 10.4 million, that is almost 10.5 million cases of COVID-19, and over 234,000 lives sadly lost in Africa due to the pandemic. For the first time since the start of this Omicron-fueled fourth wave, Africa is seeing a significant drop in new cases and a promising dip in reported deaths. Cases fell by 20% in the week to January 16th, while the number of deaths dropped by 8%. The decrease in deaths is still small, and further monitoring is needed to determine whether the trend will be sustained. However, while 4 sub-regions reported a fall in new cases, we're closely monitoring the situation in North Africa, where cases spiked by 55%. And Tunisia and Morocco have both seen an exponential increase, overtaking South Africa as the countries with the most cases on the continent. I take this opportunity to stress that while the impact of this latest peak has been moderate, the continent has yet to turn the tide on this pandemic, so there is no room for complacency. Vaccination remains our best defense against severe illness, death, and overwhelmed health systems, along with other WHO-approved prevention measures such as wearing masks consistently and correctly, as well as hand washing. So long as the virus continues to circulate, further pandemic waves are inevitable. Africa must not only broaden vaccinations, but also gain increased and equitable access to critical COVID-19 therapeutics to save lives and effectively combat this pandemic. Currently, patients with severe forms of the virus are being treated with corticosteroids, which are largely available and affordable, and medical oxygen, supplies of which remain a challenge in many countries. African countries face major impediments in accessing a full range of COVID-19 treatments due to the limited availability and high costs. For example, take antibody treatments casirivimab and imdevimab. These can help prevent people with mild to moderate symptoms from advancing to more severe diseases. But the cost is prohibitive at between $550 and $1,220 for a single dose. The deep inequity that left Africa at the back of the queue for vaccines must not be repeated with life-saving treatments. Universal access to diagnostics, vaccines, and therapeutics will pave the shortest path to the end of this pandemic. Altogether, WHO has approved 11 therapeutics which can be used to treat COVID-19. We're reviewing the data on 2 oral antivirals, Paxlovid from Pfizer and Molnupiravir from Merck, which the manufacturers report show promise in reducing the risk of hospitalization in some patients. We've been negotiating with manufacturers to secure global supply capacity and equitable and sustainable access. As a first step, WHO is supporting the shipment of a limited number of vials of tocilizumab to African countries. This immune suppressive drug is used to treat severely ill COVID-19 patients, and we're pleased to have secured these doses from the very limited global supply. So I look forward very much to today's discussion, and thank you once again for joining us.
Thank you very much, Dr. Moeti, and seasoned greetings to all. Let me turn to Dr. Andrea Howard. Dr. Howard, what are some lessons learned from the HIV response that can be applied to COVID-19?
Good morning and thank you. ICAP at Columbia University has been designing and implementing HIV prevention, care, and treatment programs in collaboration with ministries of health and local partners in countries most critically affected by the HIV epidemic for nearly 20 years. There are several lessons we have learned from our experience scaling up HIV services that are highly relevant to the design and implementation of a test and treat strategy for COVID-19. First, political commitment is crucial in order to create an environment that's conducive to the development of appropriate policy, operational guidelines, and protocols that are in line with scientific evidence and international guidelines. Second, engaging communities is critically important. We've learned that in order to reach populations most severely impacted by HIV, it is important to understand their needs and preferences. As HIV programs have evolved, it's become clear that one size does not fit all, and that services should be adapted based on client preferences so that they are acceptable and accessible. So for example, programs now offer a wide range of HIV testing options with point-of-care services widely available at health facilities, in the community, and in the home, provided at mobile and fixed sites, integrated with other services on various days of the week and at different hours of the day, and including self-testing. In addition, we have found that improving linkage from testing to treatment, including providing HIV treatment at the place of testing, improves treatment initiation. This same approach to providing person-centered testing and treatment services should be used for COVID-19. Community engagement is also important to create demand for services. By partnering with various populations, listening to their concerns, and providing them with clear and accurate information, providers can overcome skepticism, dispel myths, and instill trust in affected communities. As was the case with HIV, creating demand for services will be essential to ensure a high uptake of testing and treatment for COVID-19. Third, it is necessary to strengthen all pillars of the health system, to streamline supply chain systems for laboratory commodities and medications through investment in forecasting, procurement, and distribution to avoid stockouts, to employ task shifting to address human resource constraints, whereby basic services are provided by lower level cadres and lay workers, including adherence counseling and support, medication delivery, and contact tracing, so that more specialized professionals can focus on providing care to those more severely ill who are in need of higher level services. In addition, providers need to be trained and mentored and provided with easy to follow job aids that outline steps they need to take to administer COVID-19 tests and to risk stratify clients and assess their eligibility for treatment. Also to strengthen laboratory capacity and infrastructure, and to develop health information management systems that collect and integrate COVID-19 data from different sources in order to provide information needed for planning and managing health services, and ensuring that testing and treatment services are provided to the right people at the right time in the right place. Looking back at the past 2 decades, we've seen that in countries where there has been political commitment, community engagement, and health system strengthening, tremendous progress has been made in scaling up HIV testing and treatment to control the epidemic. And we are optimistic that the tremendous investments made in the HIV response can now be leveraged to scale up testing and treatment services for COVID-19 in the African region. Thank you.
Thank you very much, Dr. Howard. Let me turn to Dr. Harley Feldbaum. Dr. Feldbaum, what is equal access to COVID-19 treatments? Why is it so important, this equal access to treatment?
Thank you so much, and good morning, good afternoon, everybody. And thank you, Dr. Moretti and Dr. Howard. Good to be with you today. The brief answer, which I think you know, is that equitable access to all of the COVID tools that we need across vaccines, diagnostics, personal protective equipment, oxygen, and therapeutics is the only way we're going to save the most lives and get out of this acute phase of the pandemic. And sadly, this pandemic has been characterized by extreme inequities in access to those tools. And we'll talk a little bit about access to therapeutics in particular here. The Global Fund to fight AIDS, TB, and malaria has been supporting African-led responses to those diseases for almost 20 years, and now additionally supporting the response to the COVID pandemic. We've provided over $4 billion over the last 2 years to low and middle income countries across the world to support COVID diagnostics, COVID therapeutics, personal protective equipment that protects community health workers and health workers, oxygens, and other interventions. This is both to respond to COVID, to continue to support the fight against HIV, TB, and malaria, still large burdens of disease in many African countries, and to protect overall health systems. And in 2020 and 2021, some 70 to 80% of that COVID support was directed to African countries. The Global Fund is the primary supplier of non-vaccine related health products for the COVID response. And this is in conjunction with the ACTA partnership, which stands for Access to COVID Tools Accelerator, across the Global Fund, UNICEF, led by the World Health Organization, and other organizations. It's the equivalent and linked body to COVAX, which we see talked a lot about. There's no question we need more support. We're running out of money, and our ability to continue support African governments and communities respond to this outbreak is endangered. On treatments, we've had a bunch of good basic early treatments. The corticosteroids, Dr. Moeti mentioned early on, the IL-6 blockers, which have been useful for severe and critical cases, but there's no doubt treatment's going to be essential in preventing deaths and preventing further hospitalizations with stress health systems. We have two new somewhat exciting antivirals coming online. Dr. Moeti also mentioned molnupiravir, which has been shown to be 30% effective in reducing hospitalizations and deaths, and Paxlovid, which has been shown to be even more, some 88% effective in reducing hospitalizations and deaths. So those are exciting new tools that we see coming on the horizon in 2022, but there are some serious challenges we're going to have to address together. First, they're going to be in short supply. There has been a good amount of effort to make these tools available for generic production, agreements with the medicines patent pool, but there's no question they're new products in short supply, and Paxlovid in particular is challenging to produce at scale. The second challenge we need to be wary of is that they are all used most effectively within 5 days of testing positive for COVID, which Dr. Moeti also rightly acknowledged this, means we need to bring together the test and treat, actually Dr. Howard did as well, testing and treatment together in a much more rapid fashion than we've ever been able to do before, because these products are most effective, again, when used within 5 days of testing positive. And the third challenge we're going to have is that these are monotherapies today. And as we've seen with antiretrovirals, especially with a very plastic or very fast evolving virus like you have with SARS-CoV-2, we would be better off deploying these as combination therapies to avoid resistance. Those are not available yet. They're just starting to be tested, but we expect that to be another significant challenge. The final couple of things I'll just say is that we really do need to link this with oxygen provision. The scale up of oxygen is a critical component of treating people who have severe and critical cases of COVID, whether or not that's through PSA plants, concentrators, liquid oxygen supplies, and the Global Fund's been supplying almost $500 million in additional oxygen support to countries around the world. And this is critical not just for the COVID response, but for managing childhood pneumonia and other illnesses. The second thing is, again, we have to link this with diagnostics. There are cheaper self-tests increasingly become available, becoming easier to use, but the use in particularly low-income countries has really lagged. Of some 3.5 billion tests done globally, less than 0.4% have been in low-income countries. High-income countries are testing 78 times more than low-income countries. And this just hinders our ability to see where the epidemic is going. It'll hinder our ability to roll out testing and the cascade to appropriate care for severe and critical cases. And that's despite some of the really excellent work that South Africa did identifying Omicron early, but testing is just an absolutely critical thing. And the final thing I'll say is that, we just continue as ACT partners to stand by our partner countries and communities. We need more financing to be able to deliver these new therapeutic products and link diagnostic, oxygen, testing, PPE, and other products so countries can appropriately respond to this pandemic. Thanks for having us today.
Thank you very much, Dr. Falbom. Now that we have heard from all our panelists, ladies and gentlemen from the press, it's your turn to ask questions. To do this, please use the question and answer function of the Zoom application. Please remember that you will need to provide a name and the news organization you represent to have your question asked. We also have with us experts, Dr. Fiona Atuebwe, in charge of vaccines introduction, medical officer, Dr. Nonso Ejiofor, team lead for health operations, and Dr. Foster Mosha, laboratory medical officer. Without too much ado, I would like to ask the first question. Let the journalist ask if, can we confirm that we have Ed live? If not, I would like to ask the first question on behalf of Laura Lopez at the continent. And this question goes to Dr. Nonso. Dr. Nonso, does the WHO have any updates statistics on the number of countries in Africa that have access to any COVID-19 medication? And is that data disaggregated to types of treatment? Please, Dr. Nonso. And of course,
Thanks
Dr.
very much.
Moeti can add to that question. Thank you.
Okay, thanks very much, moderator and colleagues, as well as the gentlemen of the press. Please allow me to answer this question by emphasizing that there is yet to be one all-purpose drug or pill for COVID-19. And as a matter of fact, all of the drugs or all of the listed medications for the management of COVID-19 infections are used in their different combination. In terms of access, and these drugs, by the way, include medical oxygen, corticosteroids, and all of the other recently listed drugs. In terms of access, I like to say that corticosteroids and oxygen can be said to be largely available across the continent in their different degrees, but with specific reference to some of the newly listed drugs. I'll say that for tocilizumab, we got information that Cape Verde and Uganda received some shipment of this medication only within the week that passed, but also we are anticipating Ghana and Tanzania to receive additional shipments. There are discussions around the issues of access or how African countries can have access to these medications, but this is the current situation at the moment. Thank you.
Thank you very much. Thank you very much, Dr. Nonso. I have a question now from James Macharia Shege of Reuters. The question is about vaccines donations to Africa, and it is a question to Dr. Moeti. What should African countries do to avoid being offered vaccines with a very short shelf life? What would the WHO suggest? And what would be the appropriate shelf life for vaccine donations to African countries? Is it 3 months? Is it 6 months? Dr. Moeti.
Thanks very much for that question. Indeed, the issue of vaccine shelf life, vaccines expiring, and countries having to then reallocate vaccines has been an interesting and important one, as we have very much appreciated the generosity of donations to countries. We believe that this can be addressed through communication, clearly, of the intentions to donate in as timely a way as possible, allowing enough lead time for the recipient countries to be able to refine their planning and ensure that they're in a state of readiness to receive and deliver the vaccines to the population as soon as they are obtained, and with ensuring that the vaccines don't get expired. So, and I think we are seeing this more and more happen as we, as the COVAX partners, play our role in facilitating communication between the donating countries and the recipient countries. Many of the countries indicate that they would like vaccines to be donated with at least 3 months of shelf life, if not more. And we have seen that with this multilateral system, it's sometimes possible to indicate if a targeted country is not able to absorb the vaccine, then other countries that are in a better state of readiness, that have demonstrated better capacity to deliver the vaccines they receive, might then be recommended to receive those vaccines. I believe it's very much a matter of good communication. And I think that the COVAX platform, where we have many of the countries donating the vaccines, international organizations that are supporting the planning, the operations to deliver vaccines, and the recipient countries is a good platform where this exchange of information may happen. We have a lot of data about the state of readiness of countries, and we can also provide our own support. So I think the major issue is that these contributions are very important to enable us to move more towards equity and access to vaccines, and they require good communication, lead time, and support in order for the countries to absorb them optimally and cover the gaps. Thank you.
Thank you very much, Dr. Moiti. We have a question live from Ashwin from the Observer Times. Ashwin,
Yeah,
are you on?
yeah, thank you for considering my question. My question is, as per the anecdotal reports on Omicron, the people are getting reinfection of COVID-19 due to Omicron variant. Is the Omicron emerging as an immune escape for both natural and vaccine-derived immunity, when we can expect ideal characteristics vaccine for all variants of COVID-19? Thank you.
Thank you. I may ask Dr. Moiti to reply, and then maybe Fiona. Dr. Moiti.
Thank you very much. I'm not certain that I understood the first part of the question about reinfection. I think it was referring to people who are vaccinated. If the variant is Omicron, could they get infected despite being having had being infected before and despite being vaccinated? I think it's very important for us to recognize that whether it be Omicron or any other variant, the vaccines may reduce the transmission of the COVID-19, particularly those who are vaccinated are less likely to reinfect others. But these vaccines do not prevent infection, nor do they prevent reinfection. What we are primarily benefiting from the vaccination is less severe disease and fewer deaths. Will the Omicron variant cause a kind of herd immunity, which will then help to bring an end to the pandemic, as has been speculated? Certainly, this is a variant that is highly infectious, so many people are exposed. There's a certain level of antibodies in a higher proportion of the population, and fortunately, that comes with less severe disease. But I think we need to be clear that this virus is continuing to evolve, is continuing to produce more variants, and we need to be preparing for the eventuality of another of a possible more transmissible and more severe illness-causing variant, and therefore to continue with the measures that we've talked about in terms of prevention, vaccination, and other public health measures. I think that's very important.
Thank you very much. Question to the Global Fund. Will there be a scheme similar to COVAX for helping Africa access to the 11 promising treatments in the pipeline? If yes, could you tell us more about this? This is a question from Emery Makumeno, BBC News Kinshasa.
Great, happy to respond to that. The Access to COVID-19 Tools Accelerator has already been established. It was actually established at the end of April 2020. COVAX is the vaccine arm to ACTA, as the shorthand summary. And there are diagnostics pillars, therapeutics pillars, a health systems pillar, and a focus on personal protective equipment as well. So that is the collaboration of governments, scientists, businesses, civil society, international organizations like the Global Fund, Gavi, the World Bank, the WHO, FIND, and others, UNICEF, who are working together to offer access to diagnostics, therapeutics, oxygen. It is under that broad coordinated rubric that the Global Fund has supported the large variety of diagnostics, the therapeutics that have been available to date, and which is collaborating on offering the new therapeutics products, both new and old, the dexamethasone and corticosteroids, the anticoagulants, some of the IL-6 blockers, some of the monoclonal antibodies, which are, as noted, challenging to use because there's infusions and expensive and in short supply, as well as pursuing the new antivirals, molnupiravir, Paxlovid, hopefully others as they come forward. I will say this will not be easy. One of the other questions was, are we learning the lessons from vaccines? And the answer is absolutely. The challenge is they will be in short supply. They are in high global demand, and wealthy countries are acting very quickly to secure those supplies. So without additional financing, we are all in a challenging place for those of us trying to support low and middle income countries with equitable access to tools. Thank you.
Thank you very much. Maybe Dr. Moeti, would you like to comment on this?
No, I don't have anything to add. I mean, I think just the last statement indicates that we need to see to what degree we can learn the lessons from the challenges of the vaccine supply to apply to these other items and tools that are so important and in terms of influencing the behavior of decision makers. I think that our colleague, Dr. Andrea Howard, made a very important statement about political commitment and the experience from the HIV pandemic. It's just as important for this at all levels and in countries in different situations, both that those that need to make the most efforts, meaning the low-income countries that are challenged, and among the high-income countries that have the possibility to influence what happens in their own countries and what happens globally as well.
Thank you very much, Dr. Moeti. I have a question that goes to Fiona for the first part of the question, and then to you, Dr. Moeti, in general. So the question is, does WHO Africa have a sense of how many of the vaccines currently on the continent, not just COVAX, have been actually injected into arms? And what is the major roadblock to turning vaccines into vaccinations currently? So the first part of the question will be for Lady Fiona. Thank you.
Thank you very much, Elizabeth, and that's a good question. So yes, we do know, and because we follow up these vaccinations every single day. So as of this morning, we have about 500 million doses that have been delivered to Africa from all sources, and about 330 million doses that have been administered. The main roadblocks to vaccination, the first one has been hesitancy. The lack of the inadequate community engagement, reducing our ability to absorb these vaccines from the community level. But we also have had issues with disbursement of funding to countries. It looks like, yes, we do have funding from donors, but the disbursement from global level to the countries has been an issue, but also the disbursement from national level, once these funds get to the treasury in the countries, to the sub-national level where things are happening, has also been an issue. Then we have also had a problem of short expiry of doses, because even when a country receives doses that are expiring in June this year, but a month later receives doses with a 1 month expiry, the 1 month expiry becomes a crisis. So they have to scramble to use this 1 month expiry before we can now use the 6 month expiry that they had already distributed to the lower levels. But there are a number of issues that we have, healthcare workers that have not been oriented, but also hesitancy among healthcare workers, which translates to the communities, because these are opinion leaders, these are people who hold this authority to health related information. Thank you very much, Elizabeth, over to you.
Thank you very much, Fiona. I have a question from Abigail Tembo of Zimbabwe Broadcasting to Nonso and Dr. Harley. Which drugs have now been authorized for the treatment and management of COVID-19 in the world? And do low and middle income economies have access to these drugs? What do you think? Nonso first, and maybe Dr. Harley to add on.
Okay, thanks again, Elizabeth. And just to start by saying, as I reiterated before, the therapeutics or the range of medications that are listed for the management of COVID-19 cases in their numbers. We have about 11 to date. And this comprises, of course, starting with the most important, which is medical oxygen. And then we have the corticosteroids, and we have about 4 listed in that category. In addition is the interleukin-6 blockers and the monoclonal antibodies. In terms of access for low and middle income countries, the first 2, which is the medical oxygen and the corticosteroids, like I said, are quite available in the varying degrees across the continent. But for the newly listed drugs, which are, I must say, are in their very limited quantities in terms of availability globally, there are different levels of discussions and negotiation on how, especially the African continent and the low and middle income countries, can have access to some of those. I mentioned that about 2 countries have received some shipments, though in their limited numbers, but the negotiations continues, both through the Acts-A collaboration, like Felbo mentioned, but also other mechanisms for country engagement. We are considering several options, including a pool procurement for countries in low and middle income countries within the continent. Thank you.
Thank you very much. Dr. Harley, would you like to add on to this?
Just to add briefly, Nonso's exactly right in terms of the access to tools and what is available. The WHO's living guidelines online are a good guide because happily evolution of these tools is moving very rapidly. The only other thing I'd note is that these new products are in short global supply. They are hard to come by in high-income countries. And so we will have a situation throughout 2022 where these new products will need to be allocated under WHO's leadership to countries with the highest, for example, the highest number of severe and critical cases. So these scarce products have the most impact. And we are hopeful in working with producers and suppliers, not only to raise more funds, but to produce greater numbers of these so they can be equitably deployed, including local production. Thanks.
Thank you very much. I have a question from the New York Times, Lindsay from the New York Times, to Dr. Moeti and Dr. Howard. This is the question on medication and treatment. To clarify, is there a collective effort to procure treatments like molnupiravir and other new treatments? If there is a collective effort in that sense, what are some of the lessons learned from the vaccine procurement and the challenges COVAX has faced? And secondly, will WHO be looking at securing donations of new drugs as it did for vaccines donations?
Yes, thank you very much. I think that's a very important question. And I'll start and hand it over to Dr. Feldbaum, who's already said a great deal, I think, in terms of exactly this collective efforts and even what we have learned from the past. And some of the discussion around vaccinations has already touched on some of the lessons learned. I do believe that the kind of multilateral platform where information and efforts are put together is a very, very important first step. And perhaps we can see what have we learned here. We've seen, for example, with regard to vaccines, that for new products, getting emergency use licensing by WHO, that is the regulatory function of saying this is a good product, let it go ahead, is very important. So if the process of the manufacturers working with WHO in order to get that, I think is an important step then to facilitate procurement and support through a multilateral facility like the Act 8, because WHO then plays the role of providing that service in a way that it can serve many countries, some of whom do not have their capacity themselves for the regulatory work that is needed. I think that's one of the lessons learned. And I think that, you know, in order to address equity, having a common standard for identifying countries which are most in need, which are most vulnerable, is another lesson that we have learned in this joint experience on vaccines. Of course, Fiona elaborated a lot on the demand for vaccine that is a challenge now, and the need to be communicating with people, as well as healthcare workers who play a very determining role as to the attitude of the population as well, about the usefulness, the risks, addressing myths and fears in these systems. And then finally, making sure that even as we work on procurement and making supplies available, there's a lot of investment in the delivery systems in the countries and their readiness as well. These are some of the lessons that we've learned when some countries have had to say, no, thank you, we're not quite ready for the quantity of vaccine you are trying to send us. We want to make sure that as the challenges outlined by Dr. Feldbaum are reduced with regard to therapeutics, the systems in countries are absolutely ready to take them on board and to use them to save lives. Thank you. Dr. Feldbaum, I don't know if you might have anything to add in response to this question.
Nothing to add beyond your excellent answer, Dr. Moretti.
Thank you, Dr. Moretti, Dr. Feldbaum. I would like to know if maybe Dr. Howard wants to add on to lessons learned.
Yeah. Hi, hello. And just generally speaking, in terms of lessons learned, is that the question?
Yes, that was the question. It was like lessons learned from vaccines, but I mean, I think you had very valuable lessons learned from the HIV experience to offer.
Yes.
Yeah, absolutely. I mean, I think that it really, really is the lessons that we have learned is that it's very important to sort of involve all stakeholders in sort of designing and implementing testing and treatment programs, to make sure that there's constant communication with various stakeholders. As I mentioned, the incredible importance of the community. We talked a little bit about hesitancy amongst providers and among patients with regards to vaccines. So I think in terms of engaging them and making sure they have clear and accurate information, that as treatments become more widely available, that they're aware of them and aware of the safety and their effectiveness, so that we create demand for those services and that we continue to make services very accessible to populations, so that treatment can be linked to testing and treatment can be initiated in a timely fashion.
Thank you very much. I have now a question from Head Harberson, BBC News, Johannesburg. South Africa found itself at the forefront of the fourth wave caused by Omicron. Now, scientists meaning in South Africa, are fairly unanimous in saying the country is coming out of that wave. Dr. Moeti, can we declare the fourth wave over in the country?
Thank you. Yes, I think the signs are that the fourth wave is receding in South Africa, as it is as well in the continent. As I said, apart from the uptick that we are seeing in some North African countries, which are going through what would be their winter season. It's similar to the patterns that are being seen in some of the northern countries. And the government has taken the step of reducing the level of restrictions, going back to level 1, I believe it is, in South Africa. I mean, of course, I think what's very important is to ensure that the monitoring of the situation, both cases and deaths and demands on the healthcare system, is done and very much done on a decentralized level, so that whatever readjustments in assessing that the wave is down can be done on a local basis in countries. I think there's general agreement that the kind of very drastic measures of locking down countries have to be very much weighed up against the other impacts, including on health itself, of those measures. So yes, I think the fourth wave is ending in South Africa.
Thank you, Dr. Moeti. I have a question from Sophie Mokoena from SABC. Sophie, are you on the call?
Yes, Dr. Moeti, my question is directed to you. President Ramaphosa yesterday indicated that South Africa is looking at lifting the state of disaster. And yesterday we saw Prime Minister of the UK, Boris Johnson, saying that they will be lifting all the restrictions. That includes the use of non-pharmaceutical interventions, such as wearing of masks, social distance, and all of that. As the world, are we ready to really remove or lift the restrictions or the means that we adopted to manage this virus? Are we at a situation where all these announcements we can say with confidence that it is fine to take all those measures? Are we out of the risk?
Okay, thank you, Sophie, for that very good question. I believe there's no way in which we could say the whole world is out of the risk and we lift all the measures, including the wearing of masks and social distancing and some of the public health precautions at all. And we know that the context is different in different parts of the world, in different countries, and sometimes even within the same country in different places. We don't have the virus sweeping through an entire country at the same time. There are certain conditions that drive the intense transmission of the virus, particularly in overcrowded areas, in urban areas, and when people are traveling intensely. So I believe, so for example, the lifting of the state of disaster, that must be a decision that is taken in terms of some of the powers that are then implicit at the central level to control the situation. And in my view, it lends itself to what I'd mentioned before, a more localized, decentralized decision-making being informed on data. Because the fact that the state of disaster is lifted does not mean that if in a province or in a city, there is an observation of cases going up, deaths going up, these measures, the relevant measures cannot be reinstituted by the relevant authorities. So in a way, it's a bit similar to what's happening in the United Kingdom. So this will not be centralized. I heard the Secretary for Health say that some of the measures will be up to local decision makers and to some extent up to people. I believe that we need to be very, very careful about declaring the lifting of such measures as the use of masks, and we need to make sure that then the situation can be rapidly readdressed, and particularly in the highest context in terms of within in indoor spaces. Bottom line, this must be accompanied by very close monitoring of the situation right down to the local level, and accompanied by even stronger communication with people, so that where people are told, well, this is a bit voluntary, it's up to you whether you use a mask, then people understand the risks and are able to make those decisions. And in our context, that people are enabled to have the means to take the decisions that they must take. Again, data must inform all the decisions. people must be engaged in the decision-making and accept and understand why they have to take certain actions. And there's a strong drive now to learn to live with the virus and to ensure that economies recover. Because as I said, the economic devastation that we have seen, the severe impact in many of our countries also has an impact on health and will be lasting some years to come, unfortunately. Thank you.
Thank you, Dr. Moeti. I now have a question from Sho Bepu, correspondent based in Johannesburg for NHK Japan Broadcasting Corporation. And here's the question to Dr. Moeti, and maybe Global Fund if they would like to add on to Dr. Moeti's response. The question is, do you think it makes sense that some countries still impose travel bans against Southern African countries or require longer quarantine days to those arriving from Southern African countries? Do you think this makes sense?
I think my short answer to does it make sense to have travel bans against Southern African countries is actually no, because the Omicron variant, which was the reason for that, has spread virtually all around the world. And now what needs to be refined is the preventive measures for ensuring that anybody who is infected with whether it's Omicron or any other variant is not placed to spread and exacerbate the state in the country. Many countries are reviewing the duration of the isolation of people when they first enter their countries, and this is in the process of being adjusted. But the travel bans, I think today, no.
Thank you very much. Dr. Feldman, would you like to add on this?
The only thing I would add is that travel bans set a disincentive for countries rapidly, accurately, transparently reporting new pandemics, new variants of COVID or other diseases, which is exactly what we want to avoid as we seek to make the world better prepared for new pandemics. Over.
Thank you very much. I have a question now from Emery Makumeno, BBC News Kinshasa, to Dr. Moeti. I just wanted to know whether infusion or herbal treatments of any kind are also candidates for future therapeutic treatments among the 11 treatments.
Yes, if they are found through trials to be effective. So we have had several, and we are as WHO working also with the Africa CDC, have been supporting observations of some of these therapeutics. One is a product being tested in the Democratic Republic of the Congo. We are supporting that trial and the follow-up to see about effectiveness. And of course, we worked with the Africa CDC and the government of Madagascar when they had a product that they were distributing to the population and advised them on the approach to be taken in order to collect data on the effectiveness or not of this product. I'd just like to say that as WHO, we have worked for many years in supporting the development and the use of African traditional medicine, because we recognize that there are many plants and products that have huge potential to have an impact on health. What we encourage very much is the approach to documenting the efficacy and the safety of these products at a certain level, and then we are ready to support countries to make them available. We have a program of the collaboration between the traditional and the formal, so to speak, sectors of health, and this is an area that we think also has potential when it is carried out in terms of the trials to certain standards, which we have communicated to all our member states and to scientists around the region.
Thank you very much, Dr. Moeti. I have a question maybe to Fiona. This is from Frank Liu, chief reporter from the paper China. The question is, what will happen next after Omicron wave is retreating from South Africa? Shall we continually have to persuade people to get vaccinated?
That's a very interesting question. So what will happen next after Omicron? We do not know, just like we did not know what will happen next after Delta. So much as we're saying the Omicron, yes, it has low, is not as aggressive as the Delta variant or the other variants that we've seen, the other variants still continue to exist. And that is why we still see deaths that are happening. But also after Omicron, we do not know what's coming next. Could we get another more aggressive variant? That's also a possibility. Again, like we said, we are still having people in hospitals and we are still seeing deaths from the COVID-19 disease. On that note, yes, we still encourage everybody who is eligible to get vaccinated because we do not know what's happening next after Omicron. All we know is that we still have the COVID-19 with us.
Thank you very much. This is very clear. Thank you very much, Dr.
Sorry,
Sena. Yes,
if
Dr.
I may
Moiti?
add something, if I may add
Yes,
something
sure.
to this.
Sure.
Yeah, I just to say that in addition, what we have seen consistently is that being vaccinated is a good way to protect against severe illness. So I think we need to emphasize this, that, you know, it may be that the next variant is even more like Omicron, not so harmful. Whatever has happened, even in relation to Omicron, which has spread very widely, those that have been most severely affected and those that have died have been people that are unvaccinated. I think that's something that really needs to be emphasized so people understand you may get infected, but if you are vaccinated, your chances of getting severely ill and of dying are significantly reduced.
Thank you. I have another one for you, Dr. Moiti. It's in French and it's coming from RFI. The question is, la première usine africaine de fabrication de vaccins, 100% africaine, de A à Z, vient d'être lancée au Cap, en Afrique du Sud. Est-ce que l'Afrique du Sud a obtenu la cession des droits de propriété intellectuelle pour les vaccins anti-Covid qu'elle réclamait depuis un certain temps? Et quelle est la portée pour l'Afrique du lancement de cette usine?
Ok, merci beaucoup pour cette question. L'Afrique du Sud est en train de travailler, et je crois que nous avons tous entendu le président de l'Afrique du Sud qui travaille aussi avec le World Trade Organization, l'Union africaine pour essayer d'avoir cet accès aux propriétés intellectuelles. Je crois que c'est un travail qui est en cours. Ce qu'ils ont pu avoir accepté, c'est que ce vaccin produit en Afrique du Sud soit exporté aux autres pays africains au lieu d'être exporté en Europe. Donc, c'est une première étape qui était très importante. Je peux demander à Fiona d'ajouter s'il y a d'autres détails là-dessus. Je crois que la question de partage de propriété intellectuelle est quelque chose qui est très important sur lequel nous devons tous continuer à travailler au cours de situations critiques comme la crise de COVID-19. Merci.
Merci, Fiona. Fiona, Dr. Akugwe, are you still on the call? No? Sorry, Dr. Moiti, I'm afraid Fiona has network issues. So let me go to ask you another question, maybe if you may. Actually, it's a question to Dr. Falbon. Dr. Falbon, it's a question from the New York Times. It's a follow-up question, actually. WHO will help to identify the countries most in need for these new treatments. What power does WHO have to compel wealthy countries not to hoard these new treatments as the big vaccines? So it's actually a question to Dr. Moiti because it's WHO, and to Dr. Falbon if he wants to add on how things could change.
No, actually, so it's not to hoard the that's speaking, I'll ask Dr. Feldbaum to discuss it, because he's exactly, the work that the Global Fund is doing. The ACT Accelerator is an exact platform through which influence is going to be and negotiations are going to happen. So Dr. Feldbaum, if you don't mind.
Thanks, Dr. Moretti. I'll start and then hand back to you. And Lindsay, it's a very good question. There is a partnership in ACTA led with WHO to accurately distribute these new products. And so when I said WHO would be leading the allocation, that means WHO is in charge of selecting the public health criteria by which scarce products would be allocated to countries to have the most impact. That is to avoid these scarce products, the new antivirals, for example, going to countries that don't have a lot of cases or don't have a lot of severe cases or can't deploy the products, that whole constellation of issues. At the heart of your question, though, WHO is a member state organization and does not have the power to compel countries to act in one way or another. There are others who are much more expert at World Health Organization governance than I am, but I think that is one of the things at the heart of the challenges of equity that we've had. There are discussions about a pandemic treaty that may engage in some of those conversations, but those are still at a very early stage, which is why I think you've seen Dr. Tedros and WHO leadership constantly using their voice, their advocacy to argue for greater equitable deployment of COVID therapeutics, COVID vaccines, COVID diagnostics, because that is the way to the end of this pandemic. However, to my knowledge, they do not have the ability to compel countries to behave accordingly. Dr. Moretti, you may wish to add and confirm.
Yes, I absolutely agree. I mean, I think that the potential of platforms which bring key stakeholders together is to enable the kind of discussions, the agreement on certain core principles together that explain why we are all working together, having created a platform where partners bring different contributions. Some may mobilize the funding. We have different groups of countries represented on the committees or boards of some of these mechanisms. And to me, this gives the opportunity for discussions, not only in broader terms among WHO member states, but to bring on board those that are directly involved in this effort, to emphasize the fact that we're in one way or the other all in it together. I mean, certainly one cannot envisage a situation where you may have high levels of vaccination, optimal access to these therapeutics and other tools in wealthy countries, and poorer countries lagging behind. I think we've learned a lot from the vaccine situation, some of which was due to lessons not learned in the past about diversifying production capacity around the world, and that's being taken on board. And as was said very well by Dr. Feldbaum, the negotiation among member states really is around the principle of having a joint objective of equity, of improving health in the world, which is represented by the WHO Constitution. And our role is to advocate, support, and provide data that explains to wealthier countries why this generosity is in a way kind of informed by their own wish to protect themselves. While there are vulnerable situations, countries, people, the vulnerability is to some degree shared worldwide.
Thank you very much, Dr. Moeti. We are coming to an end of this virtual press conference. Let's turn to our panelists and hear any final messages. You have 1 minute each to wrap up. So let me start maybe with Dr. Howard.
Yeah, thank you so much. Sorry, thank you so much. It's really been my pleasure to participate in this discussion, and I think that I remain quite optimistic that where there is political commitment and community engagement and health system strengthening, progress has been made in scaling up HIV testing and treatment around the world to control the epidemic, and that we can now leverage these investments and these lessons learned to combat COVID-19. And I do think that similar to HIV, there needs to be sort of a global commitment to helping lower and middle income countries to meet the needs for testing and treatment to gain control of this pandemic. So thank you and good day.
Thank you very much, Dr. Howard, and really thank you for joining us at this very, very early hour at your location. Dr. Feldbaum?
Thanks, everybody, and really thanks for having us. I just reiterate two things. One, the Global Fund stands behind African nations as they attempt to respond to the COVID pandemic, build existing health systems, keep the fight up against HIV, TB, and malaria. And second, we need to do better on fighting COVID equitably and across the world. As long as we allow the pandemic to continue, as long as we have inequitable access to tools, vaccines, diagnostics, therapeutics, new variants are likely to rise, more people are likely to die than are needed to, and the health systems overall are more likely to be undermined. So we really need to do better in 2022, have equitable access to those tools to fight the COVID pandemic. Thank you.
Thank you very much, Dr. Feldbaum. And finally, Dr. Moeti.
Thank you. Thank you very much. First, I'd really like to thank my fellow panelists, particularly Dr. Howard and Ed, for having gotten up at 4 o'clock in the morning. Thanks so much, and sharing that rich and absolutely relevant HIV experience, with every word of which is applicable to what we're facing today. And just to assure you that in WHO, as somebody who's worked in that area myself, we will, in a more intentional way and more systematically, incorporate it into our advice to countries, which we've already started doing. I thank Dr. Feldbaum as well for his sharing the work that's being done in the context of the Global Fund as a financing institution. I appreciate very much the support focused on the African region by the Global Fund and the partnership in the ACT Accelerator. I mean, just to finish by saying, since we're talking about equity, I believe that the world will continue to share vulnerability in this going into the long term, since we're confronting a virus that seems to be able to change so much. So we may have vaccines. We cannot predict what will be the duration of the effectiveness of the vaccines going forward. We've seen the clinical pattern of this disease change and adjust itself, so even for therapeutics. So I believe that a sound principle is to agree that we're all in it together, and to take every opportunity to ensure that this is translated into action in terms of equity, and to express on behalf of the African region our appreciation for those countries that have come forward and shared their supplies, and most importantly, require that such platforms as ACT Accelerator will also be given the opportunity, the space, both the funding and access to the supplies, to be able to play their role of driving equity. This is the way in which we're going to overcome this pandemic. And finally, I'd like to thank all our journalist colleagues for having joined us, and for the work that you continue to do, spreading the word, informing people, hopefully influencing policymakers, technical agencies like ourselves, and individuals to take the correct actions. Thank you very much.
Thank you very much, Dr. Moeti. Thank you to the journalists who joined us for this press conference today. This is the end of the press briefing. Thank you to our panelists. Thank you, everybody. Have a nice day and a happy New Year. Keep safe.
Thank you. Bye.